I think that brings us to our next video case, which is going to be shared by Dr. Ken Chang, and he's going to be showing us navigational tunnel technique for GPOM.
Thanks, Mihir. I'll share a screen. Okay. Do you see my endoscopic view?
We do.
Okay. So this is a quick video. We actually submitted to VideoJE and it was accepted. Our advanced fellow, Jen Kolb, had helped us submit it. So, when I first started learning GPOM, one of my angst was, once I'm in the tunnel, unlike the esophagus, which is a straight shot, in the stomach, you're going somewhat uphill. And as you're trying to go uphill, you can wind up going a little bit to the right or a little bit to the left of the pylorus. And then you're in no man's land if you drive beyond that. So I started to think about ways to make it more secure, where I'm not coming in and out of the tunnel, to make sure that I'm moving in the right direction. And so that was the origin of the navigational technique. So let me
is a
play the
39-year-old
video.
female with a past medical history of laparoscopic hernia repair with a diagnosis of post-surgical gastroparesis. Her symptoms include nausea, retching, vomiting, gastric fullness, satiety, bloating, and distension with a GCSI score of 28. Her gastric emptying study showed 52% retained food at 4 hours. On endoscopy, the pylorus is snug and difficult to traverse. The navigational tunnel technique begins with cautery to mark the perimeter of the tunnel in order to guide the subsequent injection. Next, using a 25-gauge needle, submucosal injection of carboxymethylcellulose 0.5% with methylene blue starts right at the pylorus, which will serve to later identify the pyloric muscle from within the tunnel. Subsequent contiguous injections are made, backtracking to the proximal markings, which represent the entry point of the tunnel. After forming the navigational submucosal tunnel, we are ready to start the mucosal incision. Using a cautery knife with built-in high-pressure water injection, the mucosotomy is completed. The scope is then eased into the preformed navigational tunnel. Using a special coagulation mode, the knife is used to dissect submucosal tissue as well as coagulate submucosal vessels. Minimal injection of additional water is necessary within the preformed tunnel. One merely follows the direction of the prior blue injection, and it leads you straight to the pylorus. Perhaps the two greatest angst in doing a GPOM is 1, making sure you are tunneling in the right direction towards the pylorus, and 2, knowing when you have actually arrived. The pylorus is readily identified here. As demonstrated here, there was no need to repeatedly come out of the tunnel to make sure you are not straying off course. A single confirmation is made by visualizing the submucosal fluid extension onto the duodenal side. Then re-entering the tunnel, we are ready for the pyloromyotomy. Using a thinner right-angle knife, the myotomy is carefully performed using a raking technique. This minimizes the risk of violating the peritoneum. For a more thorough and robust opening, I prefer doing a double myotomy. After doing 7 o'clock, Here I am cutting at 5 o'clock, carefully extending it down to the serosal layer. Here's 7 o'clock. Here's 5 o'clock. I also like to extend one of the myotomy approximately 1.5 centimeters proximally in the prepyloric antrum. Now I come out of the tunnel and confirm minimal resistance to scope passage through the gastric outlet. The final step is closing the mucosal incision, which can be done by either suturing or, in this case, using endoscopic clips. This slide summarizes the 6 patients' tunnel appearance and angulation. Patients 2, 4, and 5 had steep angulation due to J-shaped stomachs. This summarizes the results of the 6 consecutive patients. The injection time to create the navigational tunnel averaged 2 minutes and 42 seconds. The myotomy time, whether single or double, averaged 6 minutes and 54 seconds. Most importantly, despite variability in stomach anatomy and angulation and prior Botox injections, the average tunneling time was only 15 minutes and 36 seconds. In conclusion, this novel navigational tunneling technique appears to guide and facilitate the submucosal dissection portion of the G-POEM procedure, including in J-shaped stomachs. It may increase efficiency by decreasing the need to repeatedly come out of the tunnel to check direction and prevent non-productive wandering. And finally, it may also help identify the pyloric ring within the tunnel.
All right, that's it. Thank you. If there are any questions.
Thanks, Ken. So I think that's a neat way of making sure you don't get lost in the tunnel. I think it's more relevant in the stomach where you have a larger space to get lost. I have actually seen overseas when I travel that I've seen a 1 or 2 endoscopists do the same technique for the poem in the esophagus, where they map out the tunnel length by pre-injecting all along, just like you showed, and it saves them the continuous injection that is needed. So this is a very neat technique that gets you to the pylorus. So
I think I learned that from one of your courses. I think one of your presenters talked about poem around the world, and they mentioned that, and I went home and said, "Oh, there's something to this."
That is right.
So yeah, and then so for my esophageal poem, I've evolved. I started doing complete injection, the entire tunnel, but not needed in the esophagus, as you say. And sometimes you can inadvertently hit a vessel, and then you've got a hematoma. But what I am doing now is injecting in the cardia, exactly in the lesser curve, with a little bit darker methylene blue, so I know exactly where I'm going to land. And so that's my end goal, to go down the tunnel and make sure I land in that blue space.
Got it. All right. Well, thank you so much for sharing that. I think in the interest of time, we're going to move on and go on to our next case. And I will be presenting a case of endoscopic defect closure with the X-Stack system that we talked about earlier today. So let me pull up my slides. Are you able to see my screen?
Yes.
All right, well, let me get started. So this is a patient with gastroparesis that I did a G-POEM on, and you can see here, this is a submucosal tunnel view of the nice view of the pyloric ring that we've seen earlier in other presentations, and Ken just showed it a few minutes ago as well. And so the G-POEM was done, and a myotomy was done, as you can see here. And then the incision, this time, as I'm going to show you, I closed with the X-tack tack and suture system. So this is going to be a figure-of-8 suture, where we're going to first drive that tack into, I would call it, if you're looking at like a rectangle, this is the near right side of the incision. And as I said earlier today, I make sure that we give an extra few turns so that the tack goes firmly into the tissue. Now we want to get some slack on the suture. So I'm moving away from the incision or the defect and adding some suture into the lumen. So now we have some room, we have some leeway. And now I'm going to the opposite, the diagonally opposite end of the incision, which I call as the far left. And we're going to place this tack at that site and then deploy it. And it's important here to note that you want to be away from the actual incision itself. Otherwise, there's a chance that you can actually rip through that mucosa when you're deploying the next tack. So now we are going to the near left of the rectangle that I mentioned to deploy the third helical tack. And after this is done, to not have a lot of tension on the tissue, I'm going to pull the suture a little and approximate the tissue a little more before we go on to placing the fourth tack, which is now diagonally opposite, which is the far right corner of the incision. And we're going to repeat this process and deploy that last helical tack into the tissue there. And after this step is done, the suture is then pulled to bring the tissue together. And this step of cinching this is very similar to the overstitch system. And we're going to cinch this by pulling onto the suture and pushing that cinch and then firing it, which then cuts the suture and brings that all the tacks together to approximate and close that defect. And that was my quick video, and I will end right there and take any questions.
Yeah, I think this is a great technique to close the incision line. I think this is probably cheaper than using like 6 clips, I think, to close the defect, and also cheaper than overstitch. So yeah, this is a great technique. So what's the reason why you chose the figure of 8 instead of the running stitch?
Right. So there's a few things I would like to say why I chose this to begin with. So, initially I would find that closing a G-poem incision is often harder than closing an esophageal poem incision, just because the gastric tissue is much harder to bring together. So earlier on, I used to suture. Then once we started having the larger clips, I started using the 16mm clips to approximate the tissue and then strengthen with other clips in the middle, just like the ESD case that you showed earlier. And then when X-tack became available, I thought this would be a good use to bring the tissue together. And speaking with the vendors who were supporting the case, the figure of 8 is relatively the easiest to learn, I'm told, as opposed to doing a continuous stitch. But I don't think we know the answer whether one is better or sturdier than the other one. But to answer your question, I was told it's easier to do it that way. And for G-poem, where realistically there is no full thickness perforation, all you need to do is bring that mucosa together, and that figure of 8 really works very well. I should say that there's one paper from the Mayo Group, which was a retrospective multi-center study looking at X-tack, and they showed that they were able to close all these defects, but about 1/4 of the cases they needed to add on extra clips to kind of supplement that closure. I'm not entirely sure what type of stitch was used in that case, but since it was supposed to be easier, that's what I've done, and it's worked pretty well.
Thank you. Thank you very much.
So I'm not seeing any more questions. So I think that brings us to our last case of the day. And we will go on to the next case presented by my colleague, Dr. Hazem Hamad, and he will be showing us early esophageal cancer ESD with the ProKnife ORISE ProKnife.
ESD of early esophageal carcinoma using ProKnife. A 78-year-old male with history of Barrett's esophagus with high-grade dysplasia and intramucosal carcinoma, status post-EMR in 2011 with residual Barrett's esophagus with low-grade dysplasia, status post-cryotherapy. Patient lost follow-up routine EGD in 2021, showed a 1.5 centimeter area of nodularity proximal to the EG junction. Biopsy is confirmed carcinoma. Patient reported no dysphagia. Repeat EGD confirmed a 2 centimeter area of nodularity in the distal esophagus with abnormal NBI pattern. Endoscopic ultrasound was performed and showed a hypoechoic mass with irregular borders extending into the submucosa. The MP layer appeared intact. One peritumoral lymph node was found. The node was hypoechoic and malignant appearing. Given these findings, we decided to proceed with a PET scan, which confirmed a low level avidity in the mid and distal esophagus, and fortunately, no FDG, avid lymphadenopathy, or distant metastases. A multidisciplinary team consensus was to proceed with ESD. ESD was performed using the ORISE ProKnife 1.5 millimeter. The ESD procedure started with detailed evaluation of the distal esophagus and the Barrett segments using the high-definition white light endoscopy and narrowband imaging. Marking of the lesion was done using the ProKnife. ESD was started with submucosal injection. The strategy for the ESD was to proceed with the anal side incision, followed by oral side incision, followed by tunneling from the oral side to the anal side, and then followed by opening both sides of the tunnel. This is the anal side incision using the ProKnife. Significant fibrosis in the submucosa was encountered due to prior EMR and cryotherapy. This is the muscularis mucosa, which can be thick in Barrett's esophagus and can be confused for the proper muscle layer. With the electrode pulled back inside the knife, the tip of the knife can be used for coagulation of small blood vessels. After making the oral side incision, tunneling is done under the lesion, followed by opening the gravity side of the tunnel, as shown in this clip here. Attention is then turned to the anti-gravity side of the tunnel. Submucosal injection is performed using the tip of the pro-knife, as shown here. This is followed by the dissection of the anti-gravity side of the tunnel. This again demonstrates the use of the pro-knife with the electrode pulled back inside the knife for hemostasis by coagulation of small blood vessels. After completion of the ESD, the small vessels in the base of the ESD are treated with coag rasper in the standard fashion. The ESD sites appears with no bleeding or perforation. Histopathology revealed complete resection of a 2 centimeter well-differentiated intramucosal adenocarcinoma with no lymphovascular invasion. Thank you very much.
Perfect. That's a very nice demonstration of the ORISE Pro knife. Hiro, any comments, any thoughts about this?
Yeah, so I think Hazem showed very good steps in the tunneling esophageal ESD. So he did the tunneling ESD based on the basic principle in esophageal ESD. So the reason why he opened up the tunnel from the anti-gravity side was that if you start the opening the tunnel from the anti-gravity side, usually the specimen will flip over to the other side, and that makes the rest of the ESD very challenging. So he shows the like appropriate steps for the tunneling ESD.
Right.
Yeah.
All right. I'm not seeing any further questions, and it's getting late. I'm sure in on the East Coast it's even further into the evening. So I want to thank all of you for joining us and making APIA a great place. So all our faculty, our sponsors, and the attendees, we couldn't have done this without you. And I would again want to remind you to opt in for the post-course communication with the virtual sponsors. And please give us your opinion, your feedback about how we did and what we need to do for future conferences. And be on the lookout for our announcement for next year's APIE. It will be sometime around this time of the year in 2022. Hopefully, we'll be in person, all of us getting together.